Morning, morning everyone. Hope you're well. It feels weird because it's Wednesday. Usually we're here on a Monday, 10 o'clock. Welcome if you're brand new to this as well, because we've had a few new people join recently, which is really good. So just to explain what goes on, we deliver a step-by-step guide to every region of the body. Been doing it for 3 years now, so there's a whole load of previous videos that we've done, but every year try to improve it, make it better, get more materials and videos and pictures and that kind of stuff. So so hopefully it's improved a lot since those first ones. And we start with the bones and go over all the bony landmarks, and then we build on that the ligamentous structures and connective tissue. Then we go into muscles and tendons, and then we go into blood supply and nerves. And depending on the region and the intricacies of that region, it will depend on how many weeks that takes. So obviously in the shoulder, welcome to the shoulder, the bones, not too bad. So we'll probably get that all done and dusted today. Ligaments as well, not too bad. We'll get those done next week, and then probably be able to start on the muscles. But there are loads of muscles, so that's probably going to take a couple of weeks. And then we've got a little thing called the brachial plexus, which is all the nerve network around the shoulder. So we've started that with the neck that we've just finished. So you can have a look back at those previous videos and have a look at the origins of the brachial plexus. And then we're going to build on that and extend it down the arm. And obviously finish at the shoulder, because then what we'll do is we'll move on to the elbow, and then we'll connect all of those nerve pathways in the elbow, and then we'll connect it down into the hand. And that's the same with the blood supply as well. So we'll have a look at the blood supply from the neck, and then because we've already done that, so we'll briefly touch on that, and then we'll concentrate around the shoulder for this section, and then obviously we'll take it down the arm and then into the hand. So that's the plan. Hi Martin, happy belated birthday, thank you very much, and happy birthday to you, because I believe it was yours this week as well. Imi, good to have you back. It has been a while. Yeah, welcome back, good to see you there. So today's session, it's geared at beginners because it's that early intro to the bony anatomy. But what I've wanted to do was add in some information about anomalies for this region. So when we're taught anatomy, or certainly when I was, it was obviously from an anatomy textbook, and then it was like, right, this bit's this bit, this bit's this bit, and you learn those structures, which is really good. But then you go into practice thinking that everything is like that. And that unless you're obviously hear things like this, and then you go, I didn't realize that there were multiple different shapes of the clavicle and multiple different shapes of the scapula. So that's my intention today, is just to introduce you to that and say, look, this is the basics, this is probably what you're going to need for your assessment, but going forward, if you're working with people, so this is aimed at manual therapists and fitness professionals. And if you're working with people, and especially if you've been taught postural analysis and using certain bony landmarks to assess posture, then you should hopefully find this session quite interesting. Your birthday's today. Happy birthday, Martin. Happy birthday. That is dedication indeed. Right, let's get you going then. So here's our PowerPoint for today. So yeah, bones, joints and bony landmarks, that's what we're having a look at. Let's just get rid of that on the bottom. Right, let's go. So I've bought a new model. This is from I don't get any commission, by the way, from these. I just let you know what I think are good things to buy. These are from 3B Scientific. This one's really good. What you'll see, well, when I zoom out and show you the model in a bit more detail, it's got these little pegs on here, and you can layer the muscles on. So if you're quite a visual learner and you're struggling with where the muscles go and what the the kind of, yeah, the layers of them and how they stack up and where they attach, then a model like this is really good. You can buy a basic model and just do this yourself, and you can tie bits of string or use bits of blue tack and string, because then you can redo it again and again and again as we go through adding on each layer. But this one's really good, actually. Got it a couple of weeks ago. Right, morning, Caroline. Yay! Good morning. You're going to be sick of me this week because you'd seen me on Sunday as well. Right, let's get going then. So we've got the shoulder girdle first. So what I do is I split the shoulder up into two areas. So we've got the shoulder joint, which is this bit. So that's the glenohumeral joint where your glenoid is, and we'll talk about what that is. But that's basically the socket. And then the ball section, which is the humerus. Okay, so the glenohumeral joint is the shoulder joint, and then the shoulder girdle is what the scapula attaches to. So what your shoulder blade attaches to. Okay, so let's have a look at the girdle first, and then we'll add on the joint. So the shoulder girdle is your scapula, which is your shoulder blade. So that's this section just here, just to orientate you. So if I put it that way around, this is a right shoulder. Okay, so if I keep it that way, so there's your collarbone at the front, so that's your clavicle just there, and scapula just here. So clavicle or collarbone, so that section there, and then your sternum. And you think, well, that's a bit weird. Why are you mentioning the sternum, which is your breastbone, when we're talking about the shoulder? And it's because the collarbone, so your clavicle here, attaches to your sternum at this end here. Okay, so that attaches into that point just there, underneath your trachea. And then we've got the thorax, so the rib cage basically, and that's what your shoulder blade sits on. That's what your scapula sits on. So sometimes we call it the scapulothoracic joint. So scapulo is scapula, thoracics, see the thorax, the thoracic spine, the middle section of your body. But it's not really a joint because there's no attachment of the shoulder blade onto the ribs. It's sitting in a sea of muscles. Okay? And if you saw my post the other day, I put something on Instagram, a bit of a quiz about how many muscles there are that attach to the scapula. And there are 17 that attach to that shoulder blade and help to move it around the rib cage. Okay, so there's a lot of muscles. That's why I was saying the muscle section is probably going to take some time. Good morning, Mo. Good to see you as well. Got quite a few in this morning. That's good. So yeah, the shoulder girdle is made up of these areas, these structures, and then we've got three joints, and knowing the names of the bones will help you know the names of the joints, because they look like really long words, but when you break them down, it's actually quite simple. Okay, so if we know what the sternum is, so the breastbone, and we know what the collarbone is, the clavicle, then the sternoclavicular joint is the joint between your sternum and your clavicle, so that point just there. And what you can do, if you're not really sure where it is, you can have a feel of your collarbone, feel all the way into the center, and you'll feel like a little bit of a dip. So there's something there called the sternal notch. And if you put your finger in there, where that dip is, and then you should be able to feel two bumps either side of that dip. And then if you feel right or left, whichever one it is, but whichever lump that you're feeling, if you move that arm, so I just move my right arm there, and then I can feel that sternoclavicular joint moving. And no matter what movement I do with my arm, you can feel that moving there. So even though I'm doing a shoulder joint movement, so external rotation, I can still feel that sternoclavicular joint like trying to move into certain directions. So it's really important that this joint here for general shoulder mobility is really quite mobile, because if you've got a restriction here, then that's going to affect a lot of the movements from your shoulder. So if you're doing shoulder assessments, then that's a really good place to check to make sure it's all moving okay. And then we've got the acromioclavicular. Right, so we haven't covered this one yet. Let's go back to, just switch back to here. So this bit here, so this is the back of your shoulder blade now, and there's a raised area there. So if I want to just try and get the right angle, so there, okay, can you see that raised line all along here? So that raised line there is called the spine of the scapula, and it continues all the way around to the front part. So there's your collarbone just there. So it comes all the way around to the front just here, and that bit there's the spine. And then if I just tilt that up, see as it hooks around to that bit there, that's called the acromion. Okay, so that section there, and that's going to be useful for later because we're going to be talking about differences with this this part of the bone. So that's the acromion, that's the spine of the scapula just there. And then you've got your clavicle here. So see that area there where there's that bit of plastic over there. So if I wiggle that collarbone around, that bit's attached to the acromion just there. So we've got acromioclavicular joint just there. All right, I'll pop it that way. There we go. That's a good shot there. So again, right shoulder, collarbone, and if you feel your collarbone all the way along to the end, and then you should feel like a little bit of a dip in the shoulder. It's harder to feel than this one. This one's quite obvious, but this one over here is quite flat. You can see that it's pretty much continuous, but there is a joint there, and again, it's important that that's moving well if you want good shoulder movement. Let's go back to that. And then the last one is the scapulothoracic joint. So that's the one I was saying that isn't really a joint because there's no join between a bone and a bone. This is the scapula, so shoulder blade attached to your thorax, so your rib cage, via muscles, 17 of them. Okay, and we'll have a look at those when we get to that that section in probably a couple of weeks. Okay, right. So this is another view of the shoulder. So this is quite a nice one, and this text is from the Trail Guide to the Body book. So if you do manual therapy and you need to be able to palpate certain structures, then the Trail Guide takes you through a guide basically. So there are certain areas of your body that are really easy to palpate in terms of the bony structures because they're quite superficial, and then you can use those structures to then follow it along and find some other things. All right, so if we have a look here, I'm not going to go through every single one like this, but if we have a look here, so in a seated or supine position, you slide medially along the clavicle. Okay, so in along the clavicle towards the midline to the bulbous end, so you can feel the end of the clavicle just there. Just lateral to the body's center line. So this is exactly what we were just talking about. So just the center line of the body just here where the sternal notch is, just lateral to that, so just to the outside of that. And then passively elevate the patient's shoulders. So you can do that yourself. You can elevate the shoulder, and then you'll feel the sternoclavicular joint line. Okay, so that's the kind of information that you can get from this book. So it gives you an area that's easy to find, and then follow these guidelines, and then you'll be able to feel the joints or the muscles or whatever it is that it's trying to get you to feel. So that's the sternoclavicular joint. That's the sternum just there that's a bit faded on this image. Clavicle along here. And then that's the AC joint, or the acromioclavicular joint. So that section there is the acromion, and then there's your clavicle just there. All right, and on my model there was a little bit of plastic on the top, which denotes a ligament on the top there. Okay, and there's a capsule in there as well. Cool, perfect. So that's your kind of basic introduction to the shoulder girdle. We've got the main bones, so the scapula and the clavicle and the sternum, and then obviously the thorax as well. And then the main joints, the sternoclavicular joint just here, so the that's often shortened down to SC joint, and then the AC joint, which is your acromioclavicular joint at the lateral end. Okay, so the end furthest away from the midline of your body. Right, So, that's really annoying. Scapular. So the scapular is a large flat triangular bone, and it overlies usually, okay, because there are anomalies of the scapula as well, overlies the second to the seventh rib. So there are sections on the scapula. So this area at the top here, you can usually feel that one. So that's got a specific name called the superior angle, so the highest angle. And then if we follow all the way down the inside edge of the shoulder blade down to the bottom, then that one's the inferior angle at the bottom there. So if you're trying to work out where the ribs are, you can use the shoulder blade as a rough guide. Okay, so the top bit here, so the superior angle, is roughly in line with rib number 2, so second rib, and then the inferior angle just here is roughly in line with the seventh rib. But again, everybody's slightly different. Some people have got different shapes, so give or take a couple of ribs, that's where you're going to be. All right. And I was talking a little bit about reliability and validity of tests this week as well. So if you see a patient and you say that there is an issue around the second rib on the left hand side, and you've used the superior angle as a guide for that particular patient, if you then test them again, so testing the reliability, and you feel for that area again, you will be in the same place again on that individual. However, you might not be on rib 2, you might be on rib 3. So the reliability is good, but the validity, so where you're testing, might not be so good. But if for your notes, it's useful that the reliability is good and it's you that's testing them again and again, because then you can repeat those tests. Even if you think that the area is or maybe slightly off, at least you're getting a reliable test in your notes for that particular area. Okay, so scapula, 3 borders. So we've got an inside border, so this is the medial border just here. So if I flip it around, so then it becomes my right shoulder again, so on this side. Obviously my rib cage would be here, so you wouldn't be able to see this bit of my shoulder blade, but just so it's easier to make out. So this is the medial border just here, so the inside border. There's the lateral border, so on the outside, and then we've got a superior border at the top, just here. Okay, so medial, lateral, and then superior just at the top. It's got 3 processes. So the acromion that we saw earlier, then something called the coracoid, if I can get my finger on it. So it's there, that bit there. So there's a projection out the front. Let me just switch cameras again. There we go. So see that bit just there? So that's your coracoid process. So it sticks out the front. Get that angle kind of there. See that there? So that's part of your shoulder blade, which obviously sits on the back of your body, but the coracoid comes out to the front, so it comes out here, and you can often palpate that on people. Cool, so that's that process. And then we've got the spinous process, or the spine of the scapula, which is that one there. And remember, the spine turns into the acromion just there on the end. And then the surfaces, so if I put this around again, this is my right shoulder, we've got an anterior surface, and that's sometimes called a costal surface. Costal means ribs. So the anterior surface sits on your ribs, and that's why it's often called the costal surface. And then the posterior surface around the back, that's often called the vertebral surface because of where the vertebrae are. Yeah, so rib surface and vertebral surface, because of the structures that are around it, that's why it's given those names. To make it easier, I would just call it anterior and posterior, okay, because otherwise it gets a bit confusing with some of the other names as well. Right, so we've got anterior and posterior. Right, let's have a look at that. So these videos now, these are from Ackland Anatomy, and when I was in uni, they were on a VHS. And now you can go onto their website and you can download them and get streaming access. but these are really, really good. So let's have a look at the scapula. So this is a real scapula, and if you've got access to real cadaveric material, so obviously I do trips down to London and hopefully up to Glasgow to the anatomy labs at those universities, and there is basically a box of scapula at the one in King's College in London, and you take them out and you can compare them, and they're so different. Every one is different, and you can see different shapes and sizes. There are different angles on the medial border, so sometimes they come out and like a convex, sometimes they cave in, so concavity, and same on the lateral aspect as well. So they're not always perfectly triangular shapes. There's all sorts of different variations of these. So this is your shoulder blade. Just grab my arrow just in case I need it, and then as we go through, so that's your ball and socket there. So that's the socket part, and it's called the glenoid, and we'll talk about that when we have a look at the shoulder joint. There's the coracoid process, and then this area here, so that will be your superior border, okay, and then your medial border down here, inferior angle, superior angle at the top. So at the moment we're looking at the front, and we know we're looking at the front because the coracoid is just there, and that's on the front of the shoulder blade. Let's have a look as we go through. There we go. So lateral border, superior border, medial border. There's your glenoid. So that's where your ball and socket will attach. Lateral border just here. Then there's the coracoid. There's your acromion just there. These are really important points for later, because what we'll see, we'll just pause that there. What we'll see is where ligaments attach, and where the clavicle attaches, and where the muscles attach. And that brings me on to this bit here. So this area here, this was the socket of the ball and socket, and the top part of the socket is really important because that is where a lot of injuries will occur. And you might have heard of something called a SLAP lesion, S-L-A-P. So a SLAP lesion is to do with the bicep tendon, and the biceps attaches just there. Obviously in real body, it's not just dry bones, there's loads of connective tissue, and you've got something called the labrum that sits on top of this socket, and that's where your bicep tendon will attach into. So if someone's had a SLAP lesion, that's the area that's been affected, and as we add on the tissue, it will become a bit clearer as to why that becomes a problem. And then the long head of triceps attaches down here. Okay, so you've got these little projections on the socket where the muscles will attach onto. So on the bottom part, the inferior part of the glenoid is the infraglenoid tubercle. So inferior glenoid, yeah, so that's that bit. And then at the top of the glenoid, the superior part, you've got the supraglenoid tubercle, and that's where your biceps attaches at the top, long head, and the long head of your triceps at the bottom. So that those are two bony projections that are useful to know, the supraglenoid especially. Okay, this is a good shot actually. So what we'll have a look at as we go through, we're going to have a look at the different shapes of some of these. So the coracoid usually looks like that, but there are some anomalies of the coracoid, and I'll show you some of them because it's easier to show than explain it. And then same with the acromion as well. So there are some structures that sit around here, and as we go over the next couple of weeks, we're going to fill in those structures. So the shape of the acromion is really important to someone being predisposed to having problems with this region of their shoulder, because if they have a hook shape on the end of their acromion that brings this point here down into this space, then it's not going to leave very much room for these structures to move. So that may be an issue for some people, depending on the activities that they do with their kind of mobility that they're going to have in their shoulder. So there's the spine of the scapula just there. Okay, so this divides your inferior and superior parts. Right, just pause that there. Just go back a sec. So we've got some really long names there. Let's break those down. So there we go. Okay, so this is the spine of the scapula. There's your acromion just there. Remember I said they're continuous, join on with each other. So your supraspinatus muscle goes here. Supraspinatus means superior to the spine. So that's why it's given that name, because it's the muscle that is superior to the spine of the scapula, so supraspinatus. And then there's a muscle down here which fills this space, which is inferior to the spine of the scapula, and that is infraspinatus. Okay, so the muscle names, they're named after where they are on the shoulder blade in that particular case. And then we've got this word here called fossa, and a fossa is a dip or a shallow in a bone. So anything where there's a dip, then it's given the name fossa, and there are loads of fossas all around the body. So the supraspinous fossa is the dip that is superior to the spine of the scapula. So this dip here, and that's where supraspinatus goes. Okay, so hopefully knowing some of the bony landmarks and knowing some of the terminology, superior, inferior, will help you work out what some of these things mean. So if I just play that through, there's your infraspinous fossa. So the dip that's underneath or inferior to the spine of the scapula just there. So that's where your infraspinatus will go, infraspinatus, whatever you want to call it. Cool. And then swinging around again. So there's the lateral border. There's the glenoid, so the socket. Yeah, this is a good bit. Just pause that there. So that there just came up as the subacromial space. So that's the acromion. And then underneath it, so like a submarine, yeah, subacromial, that region there, there's a lot of stuff going on in there. And we'll add that in over the next couple of weeks. But that's going to be important as well. Coracoid at the front, there's your superior angle, inferior angle, and acromion. Coracoid process just there, and there's a few muscles that attach onto that as well. Perfect. So let's just go back to this. Brilliant. So hopefully that will make this picture make a bit more sense, because when you first look at this, you're like, whoa, there's loads of stuff going on there. So I'm just going to move my arrow and me out of the way. This might be a good one where you take a screenshot if you're doing some revision for shoulder anatomy, because what it's got on there as well is all of the little tips to find them from the trail guide to the body book. All right, so there's your spine of the scapula. So this is a back of a right shoulder. So if we have a look up here, we've got right scapula, posterior view. So posterior view of the right shoulder blade. Yeah, superior angle at the top, supraspinous fossa, spine of the scapula, round to the acromion. Yeah, there's your supraglenoid tubercle, because it's at the superior part of the glenoid, and tubercle as well means lump. Yeah, so we've got different names for lumps depending on the size of them. We've got tubercles, trochanters, what else have we got? Tuberosities. Yeah, so they're all basically lumps of bone, and the reason why these lumps form is because things attach into them, muscles, and then when we move and we start to develop and we do certain activities, the muscle will pull on the bone, and then it will start to pull on the tendon, and the bone reacts to that by filling in with more bone to solidify that attachment point. So if you are a right-footed individual, so you kick with your right foot, or like a football or a person if you do martial arts, and what your standing leg, so your left leg, will be that it will develop a bigger lump on something called the tibial tuberosity, which is where your quads attach. So that standing leg, yeah, but if you're right-footed, has usually got a bigger lump on it than the kicking leg. which is a bit weird because you think, well, I'm right leg dominant. But if you think about it, the right leg when you're kicking is in the air and your left leg is on the ground. So it's doing a lot of work to stabilize your body. And it's the same as well if you're obviously right-handed and right-footed. When you're right-handed and you jump, you take off with your left leg. Yeah, so if you play basketball or netball or volleyball or something like that, and you're hitting with your right arm, you will take off from your left leg, and that left tuberosity on the tibia is usually bigger, and that's why, because we've used it more. Okay. Right, back to the shoulder. So supraglenoid tubercle, infraspinous fossa, so that area just there, lateral border, so outside border, inferior angle down here. So remember that was roughly in line with rib 7. The superior angle was roughly in line with rib 2. Yeah, and then we've got the medial border just here, and obviously we've just seen that video as well. So hopefully that all makes sense. So here are some things that you don't usually get taught. I have a bit of a fascination with anomalies with bony structures. I'm an anatomist as well as being trained as an osteopath, and when I was in anatomy school, if you like, I did my study on, I did 2 years on pec minor and the anomalies of pec minor. And then I obviously found lots of different changes in pec minor, so the attachment points and the sizes of the muscle, and in the literature. And then I was thinking, well, if it's there, it's got to be in loads of other places. So I've kind of like been searching for evidence of different structures. So we're not just looking like the textbooks. So here's your acromion differences. We've got 4 different types. So we've got type 1, which is really flat, type 2, which is curved, type 3, which has got a steep curve, and then type 4, which is curved upwards. Okay. So remember what I was saying about the subacromial space, so underneath the acromion, and it's got quite a lot of sensitive structures in that area. And especially if you play overhead sports like racket sports or throwing sports, you're going to need pretty good mobility of the shoulder, and sometimes having different shapes of acromion will affect the way that your shoulder moves, and may because you may adapt to it as well depending on the issues that you have. It may affect your ability to move in certain directions, and it's just the way you're built. So there is a test you can do, and again I put this out on social media this week, for pec minor length, so the muscle at the front of your chest. And the way that we measure it is we use a measurement on the back of the acromion as the standardized point. But you can see, depending on the type of acromion you've got, it may be shorter or it may be longer, it may be curved on that particular side, which may give you a false reading. And really interestingly, this can be, you can have someone with a type 1 on their right shoulder and a type 3 on their left. So it can vary from side to side. So then when you look at someone, you think, oh, that side's higher and that side's lower. And it's not, it's just the shape of their bones. Yeah. So it's nothing to do with the muscles holding things in certain positions. It's literally just the shape of their bones. So the maps we use for postural assessment and the landmarks we use can be different. So postural assessment is really, really difficult to be accurate with. Yeah. The only way you could be accurate is by doing an X-ray on someone. But then I think, what's the point? Okay, so round the front. So now we're looking at the right shoulder again, or scapular anterior view, so a front view. We've got the clavicle at the top, the coracoid process just here, so that was the bit that was poking through. We've got the glenoid fossa. So remember, fossa was a dip, and the glenoid is the socket. Infraglenoid tubercle, so that's where your long head of triceps attaches into there. And then this one, which is a new one, subscapular fossa. This is where a big muscle called subscapularis attaches in here. and the fossa is the dip. Yeah, so that muscle will fill that space, and when we get onto the muscles, you'll be able to see where this muscle goes onto the arm and which movements that it does. Brilliant. Right, these are the differences with some of the coracoids. So the coracoid process, which is that sticking out bit at the front just there, is often well, it's, can you see the shape of it if I put it really close? See the shape of it here? Yeah, so it's often on models and in anatomy books, that's the shape of the coracoid. But have a look at this. We've got like a peanut shaped one, like a figure of 8. Yeah, it's probably easier to see on the drawing. So figure of 8 shaped here. This one's dead straight. This one's small. This one's like a teardrop. Yeah, and then this one's really big at the front and then really small at the back. So we've got all different shapes of the coracoid where the pec minor muscle attaches. And again, if you're doing that test for pec minor, it may be that just the bones are longer on the coracoid, so that affects the position of the shoulder because of the bony anatomy rather than tightness in a muscle. Yeah, so again, we have to kind of question these things. Cool. Right, let's have a look at this. So this one has got images of a cadaver with muscles on. So if you're having your breakfast, just yeah, get ready. Okay, here we go. Right, let me just pause that there. So this is the right shoulder of an individual. There's the spine of the scapula just there. So this is what it looks like pretty much directly under the skin. So you've got the skin layer, then you've got a subcutaneous fat layer, and then you've got the superficial fascia, which covers everything. And the fascia has been removed in this case, and then we've got the muscles underneath. So that's your spine of the scapula coming round to the acromion, which will be just over here. Can you see that lump there? So that's the inferior angle of the scapula. You can see that quite easily. So there's the acromion just there. There's the collarbone, so your clavicle. And then we're into the dry bones, which is what we're used to. So clavicle just there. Scapula just there. Spine of the scapula, acromion. And then there's your coracoid. We'll just move that back again. Just move me out of the way. Okay, so scapula around the back, so that's going to be your infraspinous fossa, it just pointed at. There's your coracoid at the front. There we go, just pause that there. So we've got G, H, glenoid, humerus. This is the girdle. So remember I was saying, I split this into 2 bits. Shoulder girdle, shoulder joint. The GH is the joint. So the glenoid and the humerus is the joint. The joint here, sternoclavicular joint, that's the girdle attachment, right? And then when we link it all together, that then becomes your GH. Okay, so glenohumeral is the shoulder joint, so that's the ball and socket, and then the girdle is this bit here. So you get different movements from different bits. So the girdle, so from that bit there, you'll get elevation of the shoulder, depression, protraction, retraction. So you'll get all of those movements. From the shoulder joint, you get all the rest. So the rotational movements, hand behind back, hand behind neck, flexion, extension. But when that shoulder joint gets to certain ranges, your shoulder blade has to move. So the girdle has to move as well. So if I get to a certain point of shoulder flexion, the soft tissues in my shoulder will wind up, and then at a certain point my shoulder blade will have to move, and then when that shoulder blade moves, that's my girdle then kicking in as well. So when you're assessing, you want to assess the range of movement from the shoulder joint, and then is it the joint or the girdle or both combined that is restricting movement on someone. Cool. So humerus, glenoid, sternoclavicular joint just there. Yeah, so this is the only joint that attaches the arm to the whole of the rest of the body just there. Everything else is muscle attachments. Acromion, clavicle, so that's your AC joint. Coracoid just there. There's your clavicle. Okay, so movements, we've got elevation, so this will be shoulder girdle, depression, coming back down, protraction, and then retraction. Okay, cool. Thank you. Cheers, Martin. Yeah, I think it's the shoulder's pretty difficult to get your head around because there's so much stuff going on. But when you break it down like that, hopefully it makes a bit more sense. So this is a side view. I've got a few more minutes, so just going to try and finish this bit off. So there's your humerus, there's your coracoid. We've got these, see that bit of connective tissue there? We'll have a look at that next week. There's your acromion just there, lateral border, and then the inferior angle down here. So hopefully now all of those names are starting to become quite clear and where they are. Right, let's just finish on this then. So we've got the clavicle, and there are certain bits on the clavicle that are really important for the coming weeks. So the clavicle is a double curved long bone. The sternal end, so the bit that's near the sternum, is enlarged and triangular shape, and the acromial end is flat. And we've seen that already when you're kind of looking at it. The clavicle like joins into the acromion, nice and flat usually. Okay, there are anomalies as well. And then on the other end, it's quite lumpy. It's quite bulbous, as it's said earlier. Transmits force from the appendicular, so the appendages, your arms, to the axial skeleton down the middle, and therefore commonly fractured when falling onto an outstretched hand, and that is called a fouche injury. So fall on outstretched hand. What will happen is you put your arm out to protect you because you don't want to hit your head. If your arm's locked, then the forces will travel through your wrist, through your elbow, through your shoulder, and then if your collarbone wasn't shaped the way it was or attached to what it is, if it was really solid bit of bone, it would just go straight into your neck and you'd be dead. Okay, so because of the structure of the collarbone, it's more likely to fracture, and it's a safety mechanism because we want to protect ourselves from falling, from hitting our head, but then we also don't want that fall to send our clavicle into the arteries that are in your neck, so the clavicle fractures. Okay, so it's one of the most common fractures that we have. Varies in shape more than other long bones, thicker and more curved in manual workers, so it will adapt to what you do. And it's classified as a long bone, but there's no medullary cavity, it's all spongy. And that's important, yeah, because it's got a bit of give. If it was cortical bone, so solid bone, it would pierce your neck. But because it's spongy, we've got that protection from a fall. You're going to fracture your collarbone, but you're not going to die. Okay, so that's quite useful. These are some bits that will be useful for the coming weeks. So we've got something called the trapezoid line. You can't really see it on here. You might be able to see it on a model if you've got models at home. You've got the conoid tubercle, and then the subclavian groove. All right, so those areas are going to be useful when we start to learn the ligaments. So trapezoid line and the conoid tubercle, they're going to be really, really useful. And then lastly, I'll just show you this. These are some of the anomalies. So again, we've got different classifications of collarbones in the way that they're shaped. Yeah, so we've got a superior view, so a top-down view, and then a view from the front. And the blue, the green, and the red. So the blue, these are like the grades of the differences. So the green is like the average. The red is the end of range, like larger, and the blue is end of range smaller. So you can see the differences in the collarbone shapes and sizes between different people. And again, they may be different from side to side. So you might think that someone's shoulder is coming in on one side, and it's just their clavicle is shorter. And that's just the way that they are built. Okay, brilliant. Hopefully that was useful. So we've got a bit more to do on that next week. Let's get rid of that. So we'll be back next Monday at 10 o'clock, which is our usual time. So thank you for joining me on Wednesday. Thanks for the comments as well. If you've got any questions and you're part of the Learn Anatomy online group, then pop them into the Facebook group and I'll answer those throughout the week. And otherwise, have a good week and I will see you next Monday. See you then.